The next paper is laparoscopic ROUX-EN-Y gastric bypass is safe and effective in morbidly obese patients with cirrhosis, to be presented by Dr. Stokes.
Good morning. I'd like to thank you for inviting us to present our research. First, I'm Dr. Pope. Dr. Stokes had a prior commitment and was unable to present today. I'll be presenting our look at laparoscopic gastric bypass in a cirrhotic population. We have no disclosures to present. So the safety and efficacy of weight reduction surgery in patients with cirrhosis has not been well established. The purpose of our study was to evaluate weight reduction surgery in morbidly obese patients with an accompanying diagnosis of cirrhosis. As we all know, morbidly obese patients undergoing laparoscopic bypass generally have a wide range of comorbid conditions, and among them is included liver disease ranging anywhere from benign hepatic steatosis all the way up to and including cirrhosis. And we report our experience at our institution performing ROUX-EN-Y gastric bypass in these patients, several of which were found to have cirrhosis with the hypothesis that this operation could safely be carried out in this patient population. So just a little bit of background on non-alcoholic fatty liver disease. The prevalence in the morbidly obese population ranges anywhere from 85 to 100%. Kind of further along that spectrum in a more severe nature is an associated chronic inflammation, which is observed in about 25% of these patients, and a proportion of those, estimated between 10 and 15%, will ultimately go on to develop cirrhosis. As we know, the perioperative complications in cirrhotic patients undergoing non-hepatic surgery far exceeds that in the general surgery population. Unfortunately, there's no good preoperative indicator to tell which of these patients with non-alcoholic fatty liver disease ultimately will end up harboring cirrhosis. Therefore, proving efficacy and safety in these patients is important in order to have ensure safety in those patients which may harbor cirrhosis. So looking at non-alcoholic fatty liver disease and liver transplantation, non-alcoholic fatty liver disease is the most common liver disease in the United States, affecting 10 to 24% of the general population. This is thought to be nearly doubled in the obese population. And in patients who have progressed to cirrhosis, non-alcoholic fatty liver disease and NASH are one of the major indicators for liver transplantation. This is 2005 data from UNOS showing not only non-alcoholic fatty liver disease and NASH among the top 5 or 6 causes for transplantation, but also two of the categories which tend to be increasing as the years go on. General recommendations for treatment include weight loss with dietary and exercise modifications. Unfortunately and not unexpectedly, these modifications frequently fall short of the necessary weight loss to affect the course of the disease, and often we see relapses. There have been previous studies which have demonstrated an improvement, not just a cessation, but an improvement in the liver disease and hepatic fibrosis in patients who have undergone weight reduction surgery. These are two of the micrographs from their work on the left. These are from the same patient before and after ROUX-EN-Y gastric bypass. On the left you can see extensive fatty infiltration as well as inflammation, and on the right you see a resolution of the steatosis as well as the inflammatory changes. For our patients, we looked at everyone who presented to our obesity clinic between 2002 and 2009. Of these patients, we selected only those who underwent ROUX-EN-Y gastric bypass and looked at the patients in whom liver biopsies were done intraoperatively. They were done at the discretion of the operating surgeon at the time of operation. And only patients who received a biopsy were included in our statistical analysis. So we had a total of just over 1,200 patients during this time period. Of those 1,200 patients, 85% of which were found to be biopsied, and 11 of these had pathologic results consistent with cirrhosis. Looking at the patient populations, the two groups were similar in regards to age, BMI, and other comorbid conditions. So looking at the patient populations, the cirrhotics were found to have a slightly higher male predominance and a slightly higher percentage of degenerative joint disease. Importantly, the cirrhotics, the patients that were found to be cirrhotic, had a calculated MELD score, mean MELD score of 8, with a range of 6 to 10. So we're talking about mild cirrhosis. These were our outcomes. We see a similar conversion to open percentage, similar estimated blood loss. None of our patients required transfusions, and the length of stay was equal in the two groups. This is at 19 months follow-up. You can see that both the cirrhotics and the non-cirrhotics had similar and generous percentage of excess weight lost, around the 50% mark. So our perioperative mortality that we saw were consistent with those found by Dalal and were well below the range previously published for known cirrhotics. The known cirrhotics undergoing other non-hepatic abdominal operations had a mortality ranging between 8 and 67%, depending on the procedure in the study, which you quote. We had no mortalities to report, and Dalal had similar results. The majority of these patients in our series, and as well in Dalal's, underwent a laparoscopic approach. Theoretically, this leads to less blood loss and fewer fluid shifts, which may be protective of liver function. So further questions that we looked at were the choice of operation. ROUX-EN-Y gastric bypass has certainly become the standard operation in the U.S. There have been previous case reports with jejunal ileal bypass and biliopancreatic diversion of worsening hepatic function following these operations, and so we recommend ROUX-EN-Y gastric bypass. And then the question of the length of the roux limb, obviously a longer roux limb tends to promote greater weight loss. However, we do a traditional 150 centimeter roux limb. Again, there are case reports with that longer roux limb that there's worsening hepatic failure, and have even been case reports of these patients needing emergent transplant. Then the role for bariatric surgery in order to improve candidacy for patients who would otherwise be fit for transplant, but whose BMI are too great to be listed on the transplant list. Of note, of our 11 patients, 73% of them had weight loss significant enough that they would not be limited by the weight limit in terms of being listed for transplant. So in conclusion, we present a series of 11 cirrhotic patients who underwent ROUX-EN-Y gastric bypass with minimal morbidity and no mortalities, and achieved a mean reduction of excess body weight of 50%. We feel that this is a safe and efficacious bariatric procedure, again, for well-selected morbidly obese patients with cirrhosis, and may be an effective therapy for weight loss in patients who were previously too obese to be listed for transplant.
Questions for Dr. Pope? While he's coming to the microphone, if you saw someone who had findings suggestive of portal hypertension, I'm assuming you would stop the operation, and you would not have done those operations?
Correct, yeah.
Okay.
I think, again, emphasis needs to be placed on the fact that these are people who had mild cirrhosis and were otherwise, very well compensated. I think obviously, we would all have problems proceeding with someone in whom we thought significant portal hypertension or further disease was present.
Second quick question, though.
Sure.
The MELD scores were calculated post-operatively?
Retrospectively.
Okay. First microphone.
Abdurrahman Imari, Abu Dhabi. Thank you for a very nice study. One of the points you mentioned was potentially those patients could go to have a transplant. Now, wouldn't it be better to do a sleeve gastrectomy, because the reconstruction for a liver transplant would be very difficult after ROUX-EN-Y gastric bypass? Sure.
Thank you. Yeah, I think there are certainly technical aspects which could favor one procedure over the other. Our real aim here was to look at the safety of it in this procedure, particularly in the sense that you really don't know when you're taking these people to the OR whether or not they have just plain steatosis or if they have cirrhosis. Sometimes not clear at operation, and in order to prove the efficacy and the safety for these patients, because you don't know at the time of operation, was really our main goal here, and I think that would certainly be something for further investigation.
Hi, Alfonso Raquali from Duke University. I would like to ask you if you have any follow-up on this patient with cirrhosis that they underwent ROUX-EN-Y gastric bypass, because the big question is what happened after. That is, I think it's very important for us as bariatric surgeons to show data that there can be a very good operation to at least have a regression of the element of NASH.
Sure. So we don't have histologic findings. We haven't brought these people back for further liver biopsy. I think that's certainly the next step in this area, is to prove that there is that regression. I pointed out that there are other groups that have looked at some histologic improvement after ROUX-EN-Y gastric bypass. but we don't at this point have the histologic evidence to say that for certain that this operation does improve the fibrosis.
Last question, brief, please.
Pandey and Muller from Lansing, Michigan. So if these patients, if they develop portal hypertension later down the road, do you know what will happen, the way they manifest, like there will be esophageal varices, or what will happen to that?
Sure, that's a very good question. And the real answer is I don't think anyone has a 100% guarantee as what this patient population would look like coming back with that. I think that that's certainly something, increased surveillance in these patients. This operation doesn't eliminate the need for further surveillance and follow-up of their liver function. Further investigation would be needed if they develop signs of worsening liver function.
All right, thank you very much.